Thrilled to be here for our first meeting of the year. I'm Valerie Sullivan, I'm chair, and I am joined by our board. And I'd like to ask Andrew to list off our commissioners here today.
Thank you, Chair Sullivan. We're joined by our Vice Chair, Kaplan, designee for A&F, Dana Sullivan, designee for Department of Insurance, Rebecca Butler, Commissioner Choate, Commissioner Davis, Commissioner Edmonds, Commissioner Gentile, Commissioner Guerin, Commissioner Jennings, Commissioner McEnany, Commissioner Murphy Rodriguez, Commissioner Silva, Commissioner Sinenko, and Commissioner Sullivan. We have two additional commissioners who may be joining. That would be Commissioner West and Commissioner Chabot.
Hi, good morning. I just joined. This is Commissioner West.
Valerie, you're on mute.
Yeah. So hi, everyone. That sounds great that we've got so many commissioners here today. So let me turn this over to Matt to review our agenda, please, for today.
Thank you, Madam Chair. Welcome, commissioners. Great to see you. Happy New Year. If we can move to the agenda slide. So today we have two primary topics for your discussion. Cameron McBean, our Director of Vendor Management, will be reviewing our takeaways from our stewardship meetings. As you know, we have extensive meetings twice a year with each of our vendors to evaluate their challenges, their dynamics, review data, review their performance, and to help us understand what is happening in the marketplace. As we've said many times before, this is only one aspect of our oversight and collaboration with our carriers. Jim and his team work on a regular basis with each of our carriers, and we're constantly reviewing data. But these stewardship meetings are an opportunity to step back and evaluate performance mid-year and at the conclusion of each year. So these are important meetings for us, and as we always do, we want to circle back with you with some of our takeaways from those meetings. Following that is, of course, the next step in our process to prepare for our fiscal year 2026 coverage. We, prior in December, had started that process with a review of our expected aggregate average increase in premium for the year. And now we're back to you with a discussion of changes to the plans in the category of plan design. We will, of course, follow this meeting with our information sessions, which I'll talk about in a moment, and then come back to you for final approval of plan design, and then subsequent to that, final approval of rates. So that's today's agenda, and I'm happy to hand it back to you, Madam Chair.
All right, great. Well, I'm looking forward to hearing information from the stewardship meeting. So let's get into that. But before we do, minutes came over from our meeting in December. Wanted to see if we could get a vote to approve them.
So moved.
Okay.
Second.
So motion to approve, Bobby. Second was Eileen. So let's take a vote. I'm a yay. So Andrew, take it away.
Thank you. I just had to get off mute. Vice Chair Kaplan.
Yay.
Designee Sullivan.
Yay.
Designee Butler.
Yay.
Commissioner Chabot. Commissioner Choate.
Yes.
Commissioner Davis.
Aye.
Commissioner Edmonds.
Yay.
Commissioner Gentile,
Yes.
Commissioner Guerin.
I wasn't in the last meeting.
Are you abstaining?
Yes.
Commissioner Jennings,
Abstaining.
Commissioner McEnany,
Aye.
Commissioner Murphy Rodriguez,
Yes.
Commissioner Silva,
Yes.
Commissioner Sinenko, Commissioner Sullivan,
Yes.
and Commissioner West.
Yes.
Try Anna again. Commissioner Sinenko? You must have lost her audio. The motion passes unanimously of those voting.
All right, great. Well, then let's get in the meat of the meeting.
Thank you, Madam Chair. If we can move to Executive Director's Report. So we have provided you with a written Executive Director's Report, as we always do. Cover a couple of items here. The legislature has been busy, as you've seen in the summary, and as you'll learn a little bit more through the plan design, right through the end of session, including the passage and enactment of 2 healthcare-related bills, which have been signed into law. I will note that in addition to the brief summary in the Executive Director's Report, we have provided you in the packet for this meeting with summaries of those bills. So the first bill, known as the PACT Act, has been reviewed and worked on in several legislative sessions now. And it does a number of things. It extends the Health Policy Commission's authority to broadly include the prescription drug industry and a variety of actors in that industry into their annual cost trends hearings, and establishes an office for pharmaceutical policy and analysis, again, within the HPC to analyze trends in this industry. So these are, I think, long overdue additions to the broad market oversight and affordability of function that we rely on both CHIA and the HPC to perform. There is also notably new authority for the Division of Insurance to license and regulate pharmacy benefit managers that operate in the Commonwealth. That would, of course, include our PBM, CVS. So there are a number of big picture, long-term additions, essentially, to the framework created in 2012 under Chapter 224 that created the benchmark. And so these bring some of these new authorities into place. The PACT Act also does have one specific area of impact on the Group Insurance Commission. There are some changes to the way that generic and brand name drugs are to be placed in formularies and the cost sharing for those formularies, in particular for conditions like diabetes, asthma, and chronic heart conditions. We'll be presenting a little bit more on this in the plan design section, as I mentioned, but it's broadly designed to reduce co-payments for certain drugs on our formulary, so we'll have to make some of those adjustments. The governor also signed into law a bill called an act enhancing the market review process, and this further expands the HPC authority and CHIA authority, also the Attorney General's office, as it relates to healthcare market transactions. So aside from the prescription drug new authorities, there are new steps taken to empower these agencies on acquisitions, in the healthcare provider landscape. There are a variety of provisions in there that relate to private equity that were driven primarily by the experience with Steward Healthcare. And so there's a variety of changes made there. Again, these are big picture, long-term evolutions of these tools that have already been in place. There are some changes to the composition of commissions and that sort of thing. I will say notably, there is also a reviving here of the concept of comprehensive health resource planning in the state, which has traditionally been performed by the Executive Office of Health and Human Services. That has now been moved over to the Health Policy Commission, and anticipate that that will take new and more thoughtful shape over the years to come. The GIC is not directly impacted by any of the provisions of that new law. So we've also entered into a new legislative session, of course, and one of the early steps in that process will be the governor's release of House 1, which is the FY26 budget, which we expect next week, next Wednesday, January 22nd. So as always, we'll review the budget and track it through the process in the months to come. So that's my quick review. Oh, I do just want to also mention we have a new municipality that has joined the GIC, or that is joining the GIC starting on July 1st, the town of Holliston. Our staff has been engaging with town officials there, including a recent in-person meeting with them, and so we'll be delighted to be welcoming another municipality to our portfolio. 600 and some odd members, roughly equally divided between active employees and retirees. With that, happy to take questions. Go ahead, Madam Chair.
Yeah, and that brings our number of municipalities up to.
I think Erica has that handy. Erica?
Yeah, it's in the executive director's report. We're up to 55 municipalities and municipal entities. So that includes our public school districts, the regional school districts, and other municipal entities as well.
All right, great. Thank you.
Mm-hmm.
I will also note that we're, as we always do, we're attending the Mass Municipal Association annual conference the end of next week. Always a good opportunity for us to plug the value of the GIC as an option for more municipalities.
Great. I don't see any questions, so we can keep moving.
Great. So now I'll turn quickly to calendar review for the remainder of this fiscal year. Please note that we have 2 meetings in February. The first meeting on the 6th is where, as I said, we'll present plan design changes for a vote, and the commission with a report on what we learned during the public information sessions. And then on the 27th of February, we'll return to gain your approval of our rates, plan-specific rates for the coming fiscal year. There will be no meeting in March. Sometimes we have that rate vote the last week in February, sometimes first week in March. In this case, it makes sense to do it that last week in February, so we will not have a March meeting as we prepare for annual enrollment. Annual enrollment is set for April 2nd to May 1st, as we've informed you before. So that is our calendar. Again, as I've said before, as we move through the months ahead, we will populate the calendar and agendas with other items that we continue to work on and present back to you. So it's not a full and complete list of our agenda items to come.
All right, great. Let's keep moving.
All right, so lastly, just a quick note about our public information sessions. As you know, and as we've talked about, we've had very successful engagement with our members through these virtual sessions. We are continuing our approach and our scheduling and our design and timing of these sessions that we've had for the last couple of years by having a couple of different days, a couple of different times of day to accommodate different members, different availability and work schedules and the like. The sessions will be, again, via Zoom webinar. And the intent here is to share changes to our plans for FY26, including plan design and rates. It's also a good opportunity for us to just broadly communicate with our members about other developments that they may have on their mind. As we always do, we encourage commissioners to participate in one if you are able. They're a great opportunity for you to see how we hear directly from our members through this platform.
Great. Well, I'm confident that every commissioner will attend at least one of these. It's really good information. So that's great.
And we also, as I may have noted, we videotape, we record these and post them after the meetings on our YouTube page. So for those who may not be able to join in person, you always have the opportunity to watch those as well.
Yeah. All right. I think that's great. Thanks, Matt, and thanks to all the staff for pulling together these public information sessions. So I know I always find a lot of value in them, and I know others do as well. And then I think you said at our next meeting, you'll summarize the learnings from these information sessions.
That's correct.
So that'll be great. All right. Well, at this point, let's bring on Cameron McBean to walk us through the output of the stewardship meetings. Unless I don't see any questions, but unless someone has a question, we can keep moving.
Good morning, commissioners. If we could bounce forward a couple of slides, please. Thank you. We're going to first review on a high level what we learned from our meetings with the health plans and our PBM. Unusually, this year, Health New England had the highest increase in allowed per member per month spending trend. Historically, they've had good demographics. They tend to skew a little bit younger and healthier out there in the western part of the state for whatever reason. And we'll get into the whys and wherefores of that trend in just a minute. Point 32 also had a fairly significant trend. We also want to note that this is the first year that all of the Point 32 plans have been under the Harvard Pilgrim contracts since Tufts has exited the commercial marketplace. Mass General Brigham had a trend year over year of 4%, and WellPoint came in just under 3%. There was a pretty large disparity between the commercial and Medicare prescription plan performances. As you can see, over 13% on the Caremark side for our non-Medicare population. SilverScript, being a Medicare EGWP plan, runs on a calendar year basis. So they were reporting on 6 months of trend net of rebates. Now they did show a negative trend over that time frame. If we can move on to the next slide, we'll get into some of those cost drivers a little bit further. As I referenced before, HNE did have unusually high trend. Digging into it, they had a fairly significant increase in high cost claimants. Those are individuals whose care over the course of a year cost over $100,000 in allowed expenses. They also had higher severity or acuity in their inpatient and outpatient services, leading to higher spending on a lot of those areas. Point 32 also saw increases to its inpatient expenses. Behavioral health, which the GIC has historically considered a good thing. We are not displeased when we see increased spend in behavioral health as a rule. They also saw an increase in high-cost claimants, despite having an overall drop in their commercial membership. Mass General Brigham saw an increase in its membership. We want to note that this was the first year that Mass General was offered statewide as a broad network plan. So that may have had something to do. They said in their increased membership, they were seeing indications of higher risk scores. So the new members that were coming on to Mass General had indications that they were sicker or had perhaps more severe chronic conditions. The variability between the prescription plans, some of that is owing to changes on federal reimbursements, such as subsidies and offsets. And some of that we think is also indicative of just the different prescribing habits for GLP-1s. Generally speaking, a Medicare provider knows that Part D won't cover for weight loss. However, on an EGWP plan such as ours, GLP-1s can be covered for any FDA-approved indication. So I'm going to stop talking now for a moment and open up the floor to any questions that the commissioners may have. I also, while you're thinking of questions, we did talk with all of our providers about their contracting or all of our carriers about their provider contracting situation. It has been a challenging environment. If some of you may recall hearing that we had a number of carriers go right down to the wire in contract negotiations where provider systems were ready to, or had already sent out letters to our membership saying that we are no longer going to be able to see you because of X carrier or Y carrier. We expect that negotiation environment to continue based on the feedback we've received from our carriers. So everybody is clamoring for more money. And we are doing our best with our carrier partners to hold firm and keep those increases as reasonable as possible. Commissioner McEnany?
Hi, thanks, Cameron. So I had a question. It looks like the high-cost claimants are common to all of the plans, and I'm just wondering if they have common traits. Is it because the population is aging? Are there more prevalent chronic conditions? Or if there's kind of any additional information you can shed on what's driving the increase in high-cost claimants?
It's probably as much aging population in our demographics as much as anything. High cost claimants, they tend to be in plans pardon me, in plans our size, there's always going to be a certain number of those high cost claimants. Historically, cancer is the big driver. Chemo treatments, radiation treatments, those add up extremely quickly. Other things that can qualify as, extraordinarily or catastrophic claims could be, some NICU claims, a premature child that's born with a lot of complications. It runs the gamut, and, historically in H&E, they have had relatively fewer high cost claimants, but it's, a matter of the statistics evening out over time. This was their bad year to make up for a relatively good run, is the way I would look at it, reviewing these materials for, years and years and years. It's not an uncommon situation at all.
And I can also weigh in on some of the service category drivers. So for H&E specifically, the service category drivers were inpatient surgical, and that was driven by utilization, and hospital outpatient chemotherapy, and that was driven more by unit cost, which may also reflect some of the drug mix. And then I also just wanted to add that for point 32, this was the first year transitioning from the Tufts plans to the Harvard Pilgrim plans. So we believe that that may have impacted the overall trend as the membership shifted during that time.
Thank you. I mean, what I was trying to get at are these high cost claimants, is that going to be an ongoing trend that we need to account for, or are these kind of just one-off situations? That's what I was trying to ascertain.
Their high cost claimants are always a significant factor, but it's very hard to account for. There tends to be some fluctuation because these tend to be the most severe cases that or the most expensive cases rather.
Yeah, and I would say in the case of H&E being among our smaller enrolled carriers, one or two high cost claimants that roll through their plan can have an appreciable impact in the near term. As Cameron said, these things tend to level out as we watch them over time. So I think that's part of it as well. But as both Cameron and Lauren mentioned, what we do consistently see, this is over several years now, is that the high cost claimants tend to overlap pretty neatly with those who are taking high cost specialty drugs. Cameron mentioned, I think Cameron mentioned oncology and infusion for cancer treatments. Those are among the most expensive drugs that we see. They often coincide with those members that end up in the category of high cost claimants.
Not to belabor the point, but so I get that Health New England is a small plan and a couple of high costs might drive that up, but it seemed like it was common to all of the insurers, and I guess that's what I was getting at, right? So it's not just Health New England, it's point 32. MGB is saying they have higher risk patients. So it seemed like it's common across the board, and I understand that a bad, you can have one bad year, but this seems a little different. That's what I was trying to get at.
No, I think that's true. And again, I go back to, all of our carriers have patients who are getting treated for cancer, right? And to the degree that cancer drugs are super expensive and are getting more expensive, that is going to carry the performance of, or impact the performance of all of our plans. I think just wanted to add that H&E wrinkle that it could impact them more than others in the near term.
Jane has her hand up. If we could address the question.
Yes. I guess I want to belabor the point a little bit. I'm glad that you raised it, the question, Commissioner, about the cost. I think that for me, I wonder about those factors, because you mentioned cancer and you mentioned, I don't know, something else, the aging population. But as I think about all the key factors we hear about, including, chronic diseases and catastrophic medical events and expensive treatments, and I wonder even if there is a more comprehensive listing of drivers, just to give us a sense about just why those costs are so high. Like, for example, I even wonder about healthcare, what I'd call healthcare system inefficiencies. I worry about the lack of preventative care for certain members of the population, and if that contributes to, when they do become ill, to high costs. So I just have a number of questions. So at the risk of belaboring the point, is there anything more you could share with us on what are the drivers?
We could certainly put something together, digging a little deeper into what's driving it. Broadly speaking, the cost drivers tend to be consistent. there's always inflationary pressure. That's what we're referring to in the contracting discussion. Things just tend to get more expensive over time, it seems, in healthcare as opposed to most other industries.
Yeah, and I would just add to that trend and impacts of kind of general inflation and medical inflation over time. Those are paired here with a static threshold for high cost claimants, which is common in the industry. So a high cost claimant is any claimant that, as you see under H&E, is any claimant with claims above $100,000. So to the degree that healthcare costs continue to rise over time and we have a static threshold, there's just going to be more and more that fit that category. I've often asked whether we should adjust the 100,000 to get a sense of kind of relative to general increase in cost, whether adjustment to that benchmark may be warranted. But this is the common way of approaching identification for high cost claimants. But Commissioner Edmonds, to your point, we're happy to provide some more detail. We can figure out how to do that with the commission with some more texture and the factors behind high cost claimants. We certainly have that.
Commissioner Kaplan?
Yes, to Jane's point also on preventive care, I'm curious as to, whether the carriers have lost providers, right? Because a lot of the providers are consolidating or going to boutique services. And I was curious if people are waiting longer for particularly primary care and therefore are getting sicker.
I would say the carriers haven't lost providers. The market has when it comes to primary care. There is not enough financial incentive for doctors to pursue that as a specialty or a field when they can make so much more money and retire their medical school debt much faster by specializing in a more profitable field. The lack of primary care in Massachusetts, and in fact, the nationwide, that's not unique to us. It's not unique to any carrier or, lack of effort on the part of the insurance company to recruit providers. It's simply they're not there. They don't exist.
I was curious what impact that had on, perhaps, high cost claimants, because, I hear that a lot of people are, their primary care has retired or leaving altogether and causing people to wait longer for care. And does that translate into people going to emergency rooms instead or becoming sicker because they're not receiving, preventive care? I was just curious how that.
It's absolutely.
Cameron, if I may. So there's, it's a great question, Bobby. I think these are, as Cameron said, these are problems that all actors in healthcare are struggling with right now. I'm encouraged by some of the work that the Health Policy Commission has done around, and CHIA for that matter, on the state of primary care. They've done some excellent reporting that likely would answer some of the questions that you have. I'm happy to share those reports with the board. Also note that I do expect that the status of the primary care delivery system or sector of the delivery system is has been expressed as a high priority. It came up in a conversation, a session that the Division of Insurance did yesterday. The Senate President noted this as a high priority for her going into the next legislative session. So there is a lot of work ongoing. Again, happy to share some of those reports, and I expect that we're going to gain some more insights over the year to come, given the interest. Hope that's helpful.
Right. Yes, it is. Thank you. And I certainly would appreciate, and I'm sure my co-commissioners would also appreciate seeing those reports. I had another question regarding, the increase, in CVS Caremark, and is it all related to the GLP-1s, like that increase, or is it?
It's not all GLP-1s. That is a primary driver for the size of the increase. Utilization continues to grow with the GLP-1s. They're finding more indications, it seems, all the time. But yeah, again, and more medications come online. I think Commissioner Seneko has a question.
Yeah, thanks. I was just gonna respond to the discussion about the impact of access to primary care on like health and outcomes. And I think that the evidence on this would suggest first, yes, the access to primary care is concerning both in Massachusetts and nationally. It support what the comments from the Matt and others on that, and that I think the evidence suggests that if we had better access to primary care, that it would likely improve like quality of care. People would get care sooner that they needed, but it likely wouldn't have an impact on spending. More access to care even earlier in the like sort of process of getting care leads to higher quality, but it doesn't usually decrease spending.
Thank you, Commissioner.
And just on this topic of primary care, I just quickly confirmed what I thought, which is that there's the Health Policy Commission is meeting at noon today. One agenda item listed reads as follows: a dire diagnosis, the declining health of primary care in Massachusetts and the urgent need for action. Special report from the HPC on primary care workforce access and spending trends. So we will send that report around and the link to the meeting discussion after that meeting happens.
Thank you.
Yeah, and we had said at a previous meeting that we'd love to have the Health Policy Commission come back. So potentially a topic that they could address is follow on to the discussion they're having today, to share that with our commissioners. If the meetings in February can accommodate 35 or 40 minutes from David and the HPC. So sounds like commissioners would appreciate potentially getting firsthand ability to hear from HPC.
Yeah, we'll reach out to both our colleagues and try to find the right time to bring them in.
Thank you. All right, let's keep moving, Cameron.
Okay, if we can advance then, I will start us off with a brief discussion of some proposed plan design changes. And then we're also going to review some changes that have been made to the plan as a result of legislative mandates over the course of the last year or so, as well as most recently the PACT Act, which Matt mentioned at the top of our meeting. So through a partnership with CVS, we would like to incorporate the Hinge Health app, which is for folks with musculoskeletal conditions, so joint or back aches and pains. It's a virtual resource that can help with, physical or occupational therapy, exercises, things like that. We would like to harmonize and enhance the fertility benefits across our medical plans. In the current state for most of our plans, the GIC offers what is actually an infertility benefit, meaning you have to prove some sort of inability to conceive in order to get reproductive assistance. As a matter of equity for folks who may be in same-sex relationships, we want to make this more fair and equitable in terms of access. So removing the need to demonstrate infertility before covering intrauterine fertilization, IVF and reciprocal IVF coverage, as well as cryopreservation that is better than what we currently have in our current state. Then also as a result of our mental health parity audit, we were advised that we should remove nutritional counseling limits from those plans that have them. The financial impact of all these proposed changes is minimal at best, in consultation with the medical carriers and Willis Towers Watson. We can move on to the next slide.
Hey, Cameron, just one additional comment on that last point you make. Musculoskeletal conditions are of high prevalence within our population. I think partly that reflects the work that they do. And in addition to Hinge Health being an app that can, we're providing a resource to our members to manage their conditions at home and outside of a clinical setting, improve their adherence and performance in physical therapy. There is the hope that over time, that sort of a resource, by helping our members to giving them the tools to improve their own health and well-being, that may impact the trend that we see in musculoskeletal over time.
So,
Mr. Kaplan?
yes, I have a question. I have two questions actually. On the Hinge Health app, right? Which, so is that meant to sort of complement, let's say, physical therapy, or replace?
It is a complement, not a replacement.
Okay, so one could go to physical therapy and also use the app. Is
Yes,
that right?
It is not a replacement for an orthopedic specialist or for in-person. It is an alternative or complement. Yes.
Oh, okay. Thank you. And regarding the nutritional counseling limits, what were the limits?
One of our plans had a limit of 3 sessions, and we found through a little bit of digging, occasionally somebody may need 6 or more if they're say a diabetic working or some other. The cost impact was minimal, and it's a very rare occurrence that you need a lot of sessions. So it made much more sense simply to remove the limitation altogether.
Okay. All right, thank you.
And,
Yes.
there's a great deal more detail on this, Vice Chair Kaplan, from the presentation made by the auditors back in our November meeting. So you can look at the presentation from that meeting for more details.
Great, thank you.
Yeah.
Commissioner McEnany?
Thanks. So we've talked a lot about concern about cost, and I guess I'm just wondering if you could elaborate on what would be the minimal financial impact of the harmonizing and enhancing fertility benefits. I do understand, as you explained, that same-sex marriages may face particular issues, but it seems like it's a broad coverage, not tailored just to same-sex couples. So I'm just curious the thought behind that.
Yes, it's going to depend. The cost impact would be largely determined by how many more folks this would take advantage of this service than would ordinarily, which is hard to determine or project. But, on the high side, we think that, this might have an impact of 0.5 percentage point on one of our larger plans.
And then was the question, Eileen, about, the thought process as well, like the genesis? How did you come to
No,
this?
I understand that so much, but I guess I read it says cover IUI without demonstrated infertility. And I guess I'm just wondering why it wasn't tailored like to same-sex couples, right? It seems broader than as you described the intent, and that's what I was getting at.
Well, yeah, there are still prior authorization requirements before these procedures will be approved. Those have not gone away. So, it's not just open season. Anyone can get reproductive assistance just on demand. You've still got, there has to be a legitimate reason. You have to, if you are in a, heteronormative, whatever the correct term is, traditional relationship, trying to get pregnant, if you're, unless you're in some sort of high risk situation, perhaps older or, other considerations, no one's going straight to IVF without, some sort of prior approval process or consultation from the health plan.
Okay, thanks. That was an important clarification. Thank you.
Yes.
All right, good. All right, great.
Okay, if we could go to the next slide, please. So I referenced at the top, we have the PACT Act that was passed at the very end of December through the Senate. It will have an impact on the GIC's spend because of the mandates for coverage for certain medications for certain conditions. We're currently in the investigative and determination stage, trying to figure out which of these heart conditions are going to best comply with the mandates included within the law. Looking at the prescription changes, we're working with CVS. They are scrambling as well. It's been a short time period to get adjusted to this, and we're happy to be in compliance by July 1st. It's just a matter of trying to figure out exactly how and what that's going to look like. So I know there was a pretty comprehensive summary of the PACT Act within the executive director's report. Are there any questions on it, Vice Chair Kaplan?
Yeah, regarding the two most prevalent heart conditions, I looked at, the act, itself, and I was curious because it doesn't list, it doesn't state what those two heart conditions might be, and like who determines. So I thought I would see it in the legislation, but surprisingly it did not. So like who makes that determination?
Cameron, if I may.
Yes, please, Andrew.
Vice Chair Kaplan, the way the statute's written, it's actually the commission who's going to determine what those heart conditions, most prevalent heart conditions are for its membership, which is what we're trying to do right now. So there is no guidance whatsoever.
No, of course not. So does that mean we use data for the conditions that, I guess the majority, the two highest, or let's say the two conditions that most people seem to be treated for? Is that?
Yeah, we're working, so we're getting consultation from from Jeff from WTW from a
Right.
medical standpoint. We're looking at our own internal data on prevalence of certain medications for the category that might be implicated as heart conditions, which might be, which ranges. It could be hypertension. It could be
Right.
a whole variety
Sure.
of things. And then we've also are having CVS look at their data because their prevalence by prescription will be slightly different. We can look at indication data, the DRGs. They can tell us which drugs seem to be the most commonly prescribed. And then we have to look at, there's more guidance about the most cost-effective and has the best outcome. So we're trying to take all that into consideration, and then we'll settle on how to approach this. And the approach may be that it'll be more than 2 drugs, maybe because there's also contractual considerations once you change co-pays on rebatable brand name drugs. It has an impact on how our contract functions. So all this is being discussed.
Yeah, and I would say it's all being discussed now. The bill was just signed into law a week ago Wednesday,
Right.
and the language that emerged in the conference committee was very different from the bills that were prior in the legislature. So this is being digested by us and others as we speak. So it's going to take us a little time to sort through it and answer some of the very questions that you're asking. This is a mandate not just on the GIC, but on
everyone,
broadly on commercial carriers. So as always, the Division of Insurance will, I'm sure, is reviewing this as well and may contemplate issuing guidance to carriers. Those are not binding on the GIC, but we do frequently consult with our colleagues at the DOI to make sure that we're moving in the same direction and structuring this in a similar way.
Thanks. And is there, like, I know it's prematurely I'm asking this question, but I'm just sort of curious if whatever, 2 heart conditions, let's say you select, is there, like, can you change that? Or is that like, should we find out that, hey, those really aren't the 2, there should be 2 different ones? Or like, is that, like, do we have any idea, like, how is that going?
Well, those are all questions that have yet to be answered, and we'll have to address them over the months to come. Yeah.
All right, thanks.
If I may, Madam Chair, I guess for me, my understanding, please correct me if I am not right about this, but I understand that the PACT Act, one of the things it was trying to reduce financial barriers for people to, seek enhanced, to have enhanced health equity and patient outcomes across the Commonwealth. And one of the concerns I have is we talk about what are the heart conditions, or diabetes and asthma and all of that. We've got to keep in mind that those are illnesses, as we know, that disproportionately affect communities of color and low-income populations. So I guess I'm interested in how we make determinations about what are the 2 prevalent heart conditions, because not looking at, I want to be sure in my own mind that we are giving full attention to making those decisions in the context of understanding that there are disproportionate implications in any decisions we might make.
Yeah, no, good, all good points. I will note that the Health Equity Compact that I'm sure you're very familiar with, that has been advocating for a variety of measures to close the gaps in health disparities, had advocated for this language. And my understanding is that they have actually removed it from their advocacy agenda going forward, citing the passage of the PACT Act as kind of successful movement in that direction. But all good points, Commissioner, and we will bear those in mind as we consider our formulary going forward.
All right, move on to the next slide, please. So after the Healthy PACT Act discussion we just had, going to touch on some of the other bills that have impacted the GIC and its plans. So as we all know, as part of the last year's budget, we have finally gotten a long overdue and very welcome increase to our basic life and AD&D benefits for GIC members. That is increasing as of the fiscal 26 plan year from $5,000 to $10,000. And that also helped to pay for some of the expanded fertility coverage. We had House Bill 4918, which mandated coverage for increased high technology equipment being covered for breast cancer screening. So an MRI or 3D mammography will now be covered. House Bill 4999 mandates coverage for human donor milk, postpartum depression screenings, as well as home visiting services from individuals such as midwives or doulas. House Bill 5143 had some changes to pain management mandates, including removing utilization controls such as step therapy requirements for non-opioid pain medications. Senate Bill 2970 mandates coverage for ABA speech and occupational and or physical therapies for those members with Down syndrome. And so these are all things that we have either, currently incorporated over the last year as below the line items from a compliance standpoint with our carriers, or we are working on implementing for the new plan year as part of these, as a result of these laws being passed. Any questions before I hand things back over to Matt for some of the other considerations and wrap up that we will not be pursuing?
Yeah, Cameron, I don't see any other questions. So nice job presenting this.
Thank you very much.
I will just note before we move on, just a number of these are, as well, were passed very late in the session in December. So there's a lot of work to do in a fairly limited amount of time to make sure that we can turn around rates for year review and approval at the end of February.
All right, let's keep moving.
Next slide.
All right, so I'm going to set up the last two slides of this section with a couple of introductory comments. So we've had robust discussions in each of our meetings this year, actually starting back in September, about escalating costs and therefore premiums. In September, we talked about it as part of our strategic framework. In November, we had the Health Policy Commission presentation and our own deeper dive on our affordability challenges. And then, of course, in our December meeting, when we're discussing status quo rates, lots of discussions of what the drivers are here. And we certainly heard from you, and you've heard from us, I hope, a real sense of urgency to address these affordability challenges. And I guess I want to say that from the GIC's perspective, the staff perspective here, plan design is not primarily the right place to look for solutions to these much bigger and deeper problems. As I've said many times to this commission, my belief is that the traditional tools available to plan sponsors like us, largely around plan design and formulary changes, are not, we look at them all the time, and in my view, they're not, they don't hold the promise of making a material dent in our cost growth. That said, we have evaluated additional plan design options that have been focused primarily on bringing our premium trend down. And I'll speak specifically in two categories around GLP-1s and provider prices, which of course we've discussed at great length, and we want to bring our conclusions to you. So we want to walk through them and see why you can recommend that we are not recommending them at this time. So before we go to the next slide, just provider prices, as I've said many, many times, continue to be a core driver. They have for the last 15 years, as long as I've been in healthcare, continue to be the primary driver. And GLP-1s, of course, as we talked about in the last meeting, this presents a real conundrum to plan sponsors like us. These are highly effective, clinically effective drugs to treat obesity. They will likely be approved for additional conditions. Some already have, and there are more on the near term. As we have mentioned, we cover these drugs with a prior authorization that is a very reasonable and responsible prior auth that aligns with the FDA's approval criteria for the drug. But for these drugs, for this one condition alone, are a very material part of our increase this year that we're currently in, and as part of our projections going into 26. Just one more note on provider prices, that we rely on our carriers, and we have for many years to manage provider prices and trend. We have performance guarantees in place that hold carriers accountable for trend that aligns with the cost growth benchmark. All the financial incentives are there for the carriers to do that. But again, it's that asymmetry between providers and carriers, where the lion's share of the power in negotiating is with providers, particularly with the really highly capitalized and large systems. It's a real tough slog in the market right now to get rates, land on rates that are value-based and favorable. And this pressure is dramatically increasing, as we've said. We've heard some really outrageous rate demands from providers. So this is going to continue to put pressure on us. So with that in mind, let's take a closer look at GLP-1s and then provider prices. So for GLP-1s, we evaluated the potential of not covering these drugs, but we are not recommending that to you today. And so for context here, the GIC is one of 17 state employee health plans that cover GLP-1s for weight loss. And the vast majority do so with a prior auth that, like ours, is aligned with the FDA approval criteria. Of the states that do not cover them, the vast majority had pre-existing laws on the books or policies in place that excluded coverage for weight loss drugs, viewing them more as cosmetic in nature, so that when the FDA approved them, they did not automatically add them to their formulary because they were prohibited from doing so. So they didn't make an affirmative policy choice not to cover them. It was a result of those laws. There are 2 states that do not cover them that once did cover them: North Carolina, West Virginia. They covered them, and then as a result, primarily of the rising cost, not an evaluation of their effectiveness, they decided not to cover them. So for us, this is a difficult decision. Our projections show the cost to be substantial, but we believe that the value of these drugs to our members is high enough that we are not recommending excluding them from our coverage. We did talk a great deal about this, as I said in the last meeting, so there's a lot more that we've already covered here. So that's our conclusion on coverage for GLP-1s. The second note here about raising member cost share, we always evaluate this as part of our due diligence. So what this could look like, steps in this place that we could have brought to you, was a higher deductible for the prescription drug benefit that currently sits at $100, broadly higher co-payments for those drugs. But we continue to feel strongly that simply shifting more of that rising cost burden onto our members in that way really undermines the benefit that we provide. And ultimately, it does nothing to address the underlying inefficiencies of pricing in the marketplace. So that said, as you can see below, there are other steps that we can take outside of excluding coverage and shifting costs that are steps that we can take outside of plan design. So we want to inform you of those. These are steps that we have been and will continue to evaluate and potentially put into place to manage the cost of these drugs. Our coverage criteria is pretty mainstream, but there are ways that we can tighten this up a bit. So the best way to do this is to get more favorable pricing, right? So today we rely on CVS's ability to obtain the best net price for the GIC. But we may have an opportunity to get a better deal by working directly with one or the other of the manufacturers of the existing drugs. I would note that this is a path that Mass Health has taken. Now they have unique statutory authority that we do not have, but we are evaluating that. And we're different plans. We have had some initial conversations with manufacturers, and we'll continue to explore this area. The second bullet, we can implement other access criteria that are more stringent than what the FDA approval states. So we have a requirement today, as an example, that our members participate in a weight management, lifestyle management program, but we can make that more robust. Our colleagues in Connecticut, for instance, have contracted directly with an outside vendor that runs its own very robust program, and all their members need to participate in that program. They monitor compliance and manage access on behalf of the plan. So that comes at a cost to the state because it's a vendor, but it's the kind of solution that I think is worth a closer look. I mentioned here digital therapeutics. This is in a similar vein. Again, other purchasers are looking at these sorts of things. Then we've heard about them. Apps to engage members directly in weight loss and track compliance and progress. In some ways, similar in nature to what we talked about relative to Hinge Health and musculoskeletal. Another example is the FDA has approved these drugs for those who meet a certain BMI threshold. But BMI itself is, as a valid tool to diagnose obesity, is somewhat controversial and dated. There's actually an interesting article in this morning's Globe that I'd draw your attention to. So there may be different ways aligned with some of that new and evolving thinking about diagnosing obesity that may change how we approach these drugs. We could certainly place GLP-1s in a higher cost sharing tier, and we are evaluating that. But I think we touched on this a little bit in our last meeting, that brings complications regarding equity of access to coverage, especially for members of lower income. And I'd say the last one here, I referenced earlier that GLP-1s for weight loss approved by the FDA, there are a variety of other conditions for which these drugs are likely to be approved for the FDA. And there's rationale for the GIC to evaluate coverage for those conditions before adding them to the formulary, as opposed to letting them simply roll onto the formulary when they get FDA approval. So this is another step that we can take to sort of to manage this. So look, so there's lots that we can do on GLP-1s. I will say, just lastly, on prescription drugs, we're exploring other solutions more broadly, because it's not just GLP-1s. There are programs that a variety of vendors offer that can bring purchasers savings, but they build on the complexity of the system. Then that always gives us pause, both for our member experience, if we're implementing programs that require our members to do A, B, and C before they can get access to these drugs, just outside of prior authorization and clinical criteria. And we want to balance that with providing some savings. But some of the things that we've looked at in the past and rejected, maybe ones that we take a closer look at again. And I will say, there are a variety of other steps that other states have taken with statutory changes, new statutory authority that we don't have here in Massachusetts, that can help us, creating broader purchasing pools for certain drugs. There are prescription drug affordability boards that review the pricing of drugs and can provide some pushback to unreasonable pricing. But those are largely not in our hands because we don't have the statutory authority for those. But so what we wanted to do here is to acknowledge that this, of course, is a big challenge for us. Through plan design, we don't see tools that bring a lot of value, and so we're not recommending them. But we are moving forward with a variety of other steps that we can take that are sort of below the line of plan design, and we can continue to move on those and discuss them with you going forward. So I'll pause there. I've done a lot of talking on this. We have one more slide on provider prices, but happy to pause for any questions that members have.
Yeah, I don't see any. Why don't you go to the last slide? And it's pretty straightforward, and we appreciate your perspective. It's thoughtful. So let's keep moving. All right. So provider prices, again, I won't review how much of a driver they are for us and what we've been seeing in the market. We've already done that. But hospital-based spending in a small number of very expensive systems is really what's driving our trend. Hospital outpatient services, as Jeff Levenshires noted in our last meeting, is a significant area of growth, both in utilization and unit price. And we see pricing differentials that are substantial between standalone facilities and hospital-owned facilities. So this is not new. We have in place at the GIC already differential copays based on your site of service for both eye and gastrointestinal procedures. So you pay a higher copay if you go to a hospital-based, you pay a lower copay because it costs us less at a freestanding. So we have evaluated expanding that type of plan design to other services, outpatient surgery, imaging. And I'd say our experience with the eye and GI services has shown pretty limited success and a lot of confusion for our members. I will say too that the
delivery system for outpatient surgery and imaging is also pretty heavily consolidated under hospitals to varying degrees. But if we're going to drive members to lower cost options, if we have a concern that not a lot of lower cost options exist, then that becomes problematic. So for that, simply slapping a higher copay on a hospital-based, in our view, would seem to have limited effect. However, we are evaluating center of excellence type strategies that are more thorough and more thoughtful and balance that access concern. And we may well at a future meeting come back with a copay differential that is part of that broader effort around center of excellence. So more to come on that, but at this point, we're not recommending that. As I mentioned earlier, shifting costs to our members in this space, we believe is not the right path to go. Under other potential solutions on provider price, of course, they fall into 3 primary buckets, and each of these categories of solutions have reasons to be optimistic and reasons to be skeptical or concerned about the impact of those. These are not, as you see in the slide, these are not FY26 solutions. These are solutions that we would look to and start to prepare for application in FY27 and beyond. So the first week, Eileen, do you want to ask your question now or wait for me to finish?
Sorry, when you're finished.
Okay. Okay. So number one, we constantly evaluate the performance of our contracted carriers, and performance is variable. We've seen that kind of short-term variability in Cameron's slides from the stewardship meetings, but it is certainly in our interest to work with most closely the carriers who perform the best. So in the past, we have frozen enrollment. This is before my time. We've frozen enrollment for carriers that are not performing well. And that is always a step that we can take if it's warranted. And of course, our procurement process always gives us the opportunity to make changes in our portfolio, evaluate potential new entrants, and move on from those perhaps who aren't performing in a way that meets our needs. So, that's a little bit more like a continuation of the steps that we take today and have taken. The second category here, today our members have access to high-priced systems in our broad network plans. They pay more in premium, they pay higher deductibles and higher copays for those, but we know they have and value access to those providers. We do have narrow network plans on our portfolio, and they have their place. A substantial subset of our members are willing to make that access and price trade-off. But one way to reduce our exposure to the high-cost systems is to broadly exclude them within our plans. And we can evaluate that as we look at plan types in our portfolio as we go forward. And then finally, we can reevaluate the history that we have of reliance on our carriers to negotiate provider rates and to directly or indirectly intervene to ensure that those prices that we pay at the end of the day are fair and sustainable. So one example here, well demonstrated, as I mentioned earlier, widely varying prices for services delivered for outpatient procedures with high prices in hospital-owned facilities. Medicare is moving in the direction of paying the same amount no matter which facility you go to. And commercial plan sponsors, including us, are evaluating those sorts of steps as steps that we may be able to make. And clearly there are other broader ways that we can intervene on provider pricing, and we're watching our colleagues in other states to see if there are potential solutions that we may be able to put forward. So I'll wrap here with, we're faced with in plan design when it comes to affordability. Our options are very limited, and at the end of the day, in our evaluation of them, will produce very little savings. The better course, from our perspective, is to focus on the core drivers and develop solutions for them. We're working hard on that now, and we're getting close, I want to say. And I'm optimistic that this calendar year is the year that we can begin to dig into those with you and really start to turn the tide for FY27 and beyond. So sorry for the length of that, but we wanted to make sure that we were very clear with you on how we approached it this year, given the circumstance.
Great. Why don't you go ahead and ask your question, Eileen?
Sure, thanks. So Matt, appreciate this information and just wanted to really encourage pursuit of the potential solutions. I think that they're systemic in nature, and that's what it's going to take to change the healthcare trajectory. And I feel that the group insurance has an obligation, is one of the largest purchasers. And so really encourage you to do this. And I would ask that you keep commissioners updated in the process. I would love for us to be able to hit the ground running in fiscal year 27 and beyond with well-developed solutions.
That was
Thank
nice.
you for that.
I think we all feel that way, Eileen. So thank you. Yeah, we want to echo that again. And I know that's a follow-up from what we talked about in December.
Yeah. Yeah, we heard the call to lead, and we take that seriously.
Yeah. All right. Well, let's move on to the final topic here. We don't have Jim today.
No, given the early timing of the meeting in this month at the 16th, we're not yet at a point where we have financial statements or CFO report to give to you today. Jim, if there's anything you want to add or not to add at this point, feel free.
Yeah, I can tell you a quick verbal update that the deficit that we showed last month has not changed. So if anything, it's increased a little bit is our indication. We don't have final financial statements, but it was 100 million and it's still 100 million plus as expected, right? This month. So, but we'll give you a full report at the next meeting when we have a full month of data.
All right. That's great, Jim. Thank you. It's nice to see you.
Thank you.
All right. At this point, is there any other business that commissioners or staff want to bring up?
I have one, but I don't want to step on the toes of any commissioners.
No, it looks like you've got the floor, Matt.
Oh, is there a vice chair?
No, I just wanted to thank you, Matt, for you and Cameron for the very comprehensive, presentation today. It was really a really good discussion, but thank you for all that information. I really appreciate it.
Wasn't my intent to filibuster, but to explain where our heads are at, because it's an important moment for us all. And we acknowledge that. The point that I wanted to make, Madam Chair, is just to remind our commissioners of the dates for the information sessions. Again, would love to have the assistance of our colleagues in labor and for retirees to spread the word about those. We'll be passing out information about those at the MMA next week. We're in the process of informing our members as well, but any assistance that you all can provide would be greatly appreciated.
Yeah, that's a great point. And if you've got websites, I'm sure it would be great to have, and you probably already have it on there for education and outreach. So good point. So great. All right. Well, at this point, if we don't have any other business and I don't see any hands up, I will entertain a motion to adjourn.
So moved.
Robbie? I need a second. So Catherine, second. So I think we can just all in favor, say aye.
Aye.
And we'll see you next month. All right. Stay
Thanks.
warm, everyone.
Bye-bye.
If you're in the
Thanks.
Boston area, it's chilly. All right,
Thank
bye.
you.